examination of arterial pulse who have attended or who know. Attended means if you have not attended, you have to know by this time. Examination of arterial pulse, how to do it, uh, which is the most common artery chosen for examination of the arterial pulse? Radial artery. That everybody of you know. What is the cause of choosing that? One, if you have to answer it in a single phrase, if not a single word, it is easy access. Easy access. If in a single phrase, if so, it is easy access or convenient location. So hence easy access. But still there are some points to follow. That means it should not be actually called precautions, but some procedural methods to follow. So if you go through the books, it is written the wrist, you have to wrist joint, at the wrist joint it has to be semiflexed and semipronated. Now by now it is already 2-3 months into classes. By now you should well be aware of these terms: flexion, pronation, supination, and all these things. So there is no more scope to explain these things repeatedly, but still I'll say, for those who have joined late, if you are still not acquainted, then think of the anatomical position. I think all of you know about the anatomical position. So this is the anatomical position. So in the anatomical position, just think of everything. Whenever you hear these kind of terms, try to think of the anatomical position and then try to think. Many things can't be, some things can be explained even without the anatomical position. But what is flexion and what is extension, you try to, when you try to first visualize at the anatomical position, which will be the most simple example. I think this moving at the movement of the elbow joint. So flexion is this elbow joint. What are the two arms? This arm does not mean the actual arm. What are the three parts of the, what I go on telling repeatedly as medical personnel? So what should you tell? So in layman's terms, this upper limb is called the hand, but in medical terms, the shoulder joint to the elbow joint is the arm, the elbow joint to the wrist joint is the forearm, and for the palm and the back of the palm, the whatever is distal. Again, this term, what does distal means? Away from the heart. So one relation of one organ or one part of a body part to another. So whatever is distal, so the distal most part of the upper limb is the hand, that is the wrist joint to the wrist, including the fingers. So this is the hand. So the flexion during describing movement at a joint. So two arms of means this is not the arm, which is the part of the hand between the shoulder and the elbow joint. This is just the two arms of the elbow joint, or this movement are the arm and the forearm, or the two sides, that means. Okay. So the joint, this arm, the forearm is coming towards the arm during flexion movement, and the forearm is going away from the arm during the extension movement. Similarly, flexion of the knee, the back of the calf muscles will go towards the back of the thigh. That is which compartment that is, or which muscles are there? You should answer better. Oh, anyway, inflex has not been done. No? Okay. Hamstring muscles, quadriceps muscles, have you heard of till now? No. Okay, leave it to the back of the thigh, the calf muscles on the posterior aspect of the leg, which is the, at least which is the thigh. Again, this is between the thigh. So what are the parts of the lower limb? Thigh, leg and foot. So which is the thigh is the part between the hip joint and the knee joint. Between the knee joint and the ankle joint is the leg, and distal to the leg is the foot. So just see again, just think in anatomical position, just to mention, nothing to do with this topic. In the hand, in the anatomical position, the thumb is the lateral most finger. So I am just mentioning these things for the newly admitted students, relatively newly admitted students. You should know this by now. So thumb is the lateral most, but in the case of the foot, the there the thumb, the corresponding finger for the thumb is the great toe, that is the medial most. So what are the meaning of the terms lateral and medial? Lateral means away from the midline, medial means towards the midline, and one in respect to one another. So in case of the simple examples, in case of the say hands, the finger, say the middle finger is medial to the index finger but lateral to the ring finger and small finger, medial to the index finger and the thumb. Thumb is the lateral most, nothing lateral to it in terms of the talking of the fingers. Small finger or the little finger is the, not small finger, little finger is the medial most, others are lateral to it. So this is the meaning of the term. When you talk of the internal structures, you have to understand it like that. Medial means that is more towards the midline. Than we talk of two organs or two parts of the same organ, one artery, one vein, one nerve, whatever. So in anatomy, it is medial means medial, this is medial to this structure is medial to this, that structure means this first structure is towards the midline, more towards the midline than the second one, which is in that description. So these are preliminary things which you should be acquainted with when discussing various topics. So during discussion of the pulse or during noting the arterial pulse, most common is the radial artery due to chosen is the radial artery due to easy access. Although all peripheral arteries, to examine the arterial pulse in detail, all peripheral arteries possible should be examined, including all in the lower limb, in the upper limb. So radial artery, the ulnar artery, the femoral artery in the lower limb, all these peripheral arteries, not the big arteries which are called what is the big artery or the large artery are arising from the left ventricle of the heart, it is called the aorta. Not those, but the peripheral arteries. So they should be examined for examining of the peripheral pulse or examining of the arterial pulse. Most commonly we do it on the radial artery due to convenient location, easy access, and during clinical examination, as we have talked of in the clinical examination, there are some criteria of clinical. Those who still don't know, please note it down. Note it down means you don't have to write, everything is given in books. Just note that these things you have to follow not only for the exam, not only the purpose of a professional course, this is a professional course. This is not like some courses you study about one thing, later in a professional life go and do some another thing. If you want to be a professional doctor, if you want to earn as a doctor, then you have to know these things. This is not just about passing the exam. So for the exam as well, for your future, so there are some criteria to be followed during physical or examination. That is, we have talked of those things. General physical exam, what are the criteria? Daylight, broad daylight is the most suitable. If not possible, then at least bright light. The room where you are doing it, the area where you are doing it should be well lighted. The consent of the person should be taken, and all the subject has to be made comfortable. What is the difference between subject and I'll ask one, please don't answer together. What is the just literal difference between subject and patient? Can you tell me? That means any individual. No, subject is any individual who comes for medical advice, medical consultation, or wants some medical advice. Strictly speaking, we call him or her as a subject. But in whom there may be cases where you, as a medical professional, just note that this person came from medical advice, but physically there is no physical ailment detected on, at least overtly, on general physical examination, and maybe some basic laboratory investigations, nothing detected, no intervention required. This you have the right as a medical professional, not that you have to write a few, prescribe a few medicines as soon as a subject comes to you and a person comes to you and asks for medical advice. So that is upon your judgment as a medical professional. So that individual is called a subject. But if some ailment, if some issue is diagnosed, then that individual can be called a patient. So this is a difference. So the subject at first, when say your first meeting with an individual who has come for medical advice, so he or she should call the subject, but before the physical examination and history taking, the subject is to be made comfortable. So these are some criteria for physical examination which is to be followed. If the subject is, in books it is written, if the subject is a female, you should have a female attendant, but this is most probably because, again I say on record, because earlier female medical professionals, at least doctors, were very few in number. So I think that is the reason, my opinion, that is the reason books are writing like that over. But I have already given examples. I can give examples from my, that means, own experience as a subject, that it is also important that if female medical professionals are there and the male subject is there, I can give an experience give an example from my own experience, that I was waiting for an ECG to be done, but there was no male attendant during that, and the lady who was there to do the ECG, the lady doctor, she was quite hesitant, and after 10 minutes she asked me, should I proceed, because the male attendant will be late to arrive. He has gone for some sent for some other purpose, so there was only one male attendant available. So what actually happened was that I told yes madam, because something happened that the ECG was to be done readily. Actually the ECG took place after 20 minutes or so, and by that the findings which were expected were not found. So these are major issues in practical life. So better or not better, it should be that for a male subject, male attendants are available if the medical professional is a female one. So you say it as that if the subject is of the opposite gender as that of the medical professional, then there should be an attendant who is of the same gender as that of the medical professional. This thing, and mostly the medical professional, you will be examining the individual from his or her right side. So sometimes in cases we can move on to the left side, but most physical examinations are possible from the right side. Again, the cause of this is probably because one cause of this, why is it, most of the human beings, most of us are right-handed. So I don't know anyone in this room right now, is anyone left-handed? Left hand is the dominant hand. Anyone? So this is rare, but even if one is left-handed, still examinations can be done from the right side. This is not so strict, but still this should be followed. But making the environment comfortable for the subject, this is mandatory. You can't just make the subject uncomfortable and go carry on physical examination, and privacy has to be there. And this thing, that male attendant for male subject, female attendant for female subject, especially if the clinician or the medical personnel is of opposite gender, these criteria are to be followed. So and besides this, for some individual clinical examinations, there are some specific criteria, like in case of pulse, these are just related to convenience and approach to that particular physical examination. So during examination of the arterial pulse, to make the radial artery, so that, see, this will depend, if the person is obese, it will not be so easy to locate. So these are some practical issues. So it is better that you just semi-flex and semi-prone. So flexion means that, again, at the wrist joint, means bringing the wrist towards the forearm. This is possible to this extent, like the forearm is possible almost during flexion of at the elbow joint. Forearm, it is almost possible to align to the arm, not wholly, but maybe up to 10 degrees or so. But in case of the wrist joint, it will, but still semi-flexion, that means half of what is almost, this is not exactly half, but almost half of what is possible. And pronation means, supination is not in anatomical position. Supination means lying on a horizontal surface. The back is lying, touching the horizontal surface. The back is on that horizontal surface, and the front, or we should not say front or back now as medical personnel, we should say the dorsum of the body and the ventral portion, ventrum, dorsum and ventrum. So the dorsal portion will be on the horizontal surface, ventral portion will be above. Okay, and if it is opposite, it is pronation. You may heard of it, this term during COVID times. To, if in case of respiratory difficulty, just a homely simple thing at home, it was told that if you are facing respiratory, obviously visit the medical professional, the hospitals and all, but if there is a respiratory difficulty initially, you can try pronating yourself. That means one can try pronating oneself, and just the respiratory difficulty, this breathing issue may be reduced to some extent. So that is pronation. That is, usually we lie supine, but just turning around. Turning around means now the dorsal portion will be on the horizontal surface, sorry, the ventral portion will be the horizontal surface, the dorsal portion will face upwards. So semi-pronation means just pronate, this is, or pronation means the hand will be, at the wrist joint will be turned like this. So semi-flexed, semi-pronated, and then you try to locate the radial artery just beside the, what is called the styloid process. You should know it by now, as superior extremity has been discussed. Styloid process of the radius, very radius, that is the bone, that is, which is very prominent at this lateral end of the wrist joint. So one of you just come forward, just volunteer, you. There is no tool over here, so just bring your chair. Sit. So remember, during, just why I call, we could have, we'll be doing it in the clinical lab itself, the clinical room, but why I brought him over here, just to show you a few simple things that during taking consent. So some of, as beginners, you will have this, some develop this habit. So I'll examine the arterial pulse. Do you agree? Okay. Yes. So do you agree? Okay. Probably the subject will not be saying no, because he or she himself has come for physical examination. When he can say no, there is, and this is a this is something we should talk of. When there's maybe some issue during examination, or obviously during examination of private parts. Okay, as you go on examine, there will be necessities when during examination of private parts there may be some issue, but mostly the answer will be yes. But firstly, when we are to talk of, when you have to say that we are going to examine, or we have to explain about what medical examination has to be done, that has to be done. But during examination of pulse, you may say, we will examine the pulse, do we agree? Okay, probably the subject will say yes. During examination of the private parts, the subject may initially hesitate, but that is the purpose, that you have to counsel him or her that this is needed for your that means betterment, or whatever ailment you are facing. So we need to examine. There is someone, maybe someone from his or her household is there, the subject's household, some male attendant or female attendant from the hospital or from your clinic is there, but the subject has to be made comfortable. But in many cases, you won't require to just explain what you are doing. So you don't need to say, that means most of you know by now, I think, what are the points to note in general physical examination. Now I'll examine for cyanosis. So that doesn't mean much to him or her, because he or she is a layman. I'll do some physical examination. Please cooperate with me. If you feel uncomfortable at any point, then please tell me. Okay, this should be the communication. Not that I'll examine your pulse now, I'll examine, okay, blood pressure, the subject is going to, that means he or she will in most cases understand that what is to be done, the blood pressure cuff is to be tied and all. But in most cases, what will be, it is no point explaining that I am now going to examine for cyanosis, I am now going to examine for jaundice. You just do the examination by saying that I will just examine you, please cooperate with me. If you have any problem in the middle of the, that means during the course of this physical examination, just report, and you start. And when you will become professionals, you will see that even before becoming professionals, you will see it will not be possible to explain also. You will just go on examining one by one. So say pulse, blood pressure, temperature, and if you just have told the subject, you should have told the subject, or you should tell the subject beforehand. If you feel any problem, then you just report to me, or you just utter that, but nothing else. Now there will be special cases, obviously, when if you say the subject can talk or something, if there is some problem, probably there will be some household member who will be with him or her. In case of children, it is not possible, it is always not possible for them to explain by themselves. So probably the mother of the child should be there, like this, a guardian will be there. So I am going to examine, just cooperate with me. Okay. Now if you ask like this, the purpose of calling him over here, if you ask like this, the semiflexed and semipronated your hand, this sounds foolish, because the subject is again a layman. So either you have to show it, that do like this, you have to show it by yourself, in this case that do this, then probably, and after 1 or 2 times, showing it 1 or 2 times, the subject will be able to repeat it. The subject won't be a medical professional in most cases. So otherwise you have to do it by yourselves. There are few areas of this clinical examination where there is active involvement is required and some are passive. Here you may do it by yourself, just hold the subject's hand, and there is no need to make a fist. If the subject does something, this may be there, the subject makes a fist. So what he did right now, this may be there, that there is, then there is no need to make a fist, or just unfist it and you just give these instructions. Okay. So just you semi-flex and semi-pronate, you do like this by yourself. Otherwise you may show it and the subject will do it by himself or herself, but don't just tell him or her that semi-pronate your hand. The subject will understand nothing in most cases. So after doing this, you place your hand, you spot the styloid process, and then just place 3 fingers beside that. Now as I am a right-handed person, I should do it by the right hand and supporting the forearm of the subject like this. Okay, place the 3 fingers of the right hand, and the rest is easy. After locating the radial artery, 3 fingers, if you find if you have noted the pulse, that means the thread will do it in the lab, no need to do it here, we'll do it in the clinical lab. Don't just start doing it over here sitting in the class room. So after locating the pulse, just you have to, the first step is to count it. So as beginners, if you have not done till date, most of you have done, I think, but you have joined late, if you have not done a single time, then you have to, as beginner, the first point is to be counted. You can go. Okay, you can go now. Okay. Thank you. We'll do it there. Thank you. So as beginners, you first just count it. But the problem is that till the end of this first year of medical school, you don't go beyond counting, and you just report as, when you are asked to report about the examination of the arterial pulse, candidates are uttering in the examination, it's like this, 80, 90, 70, like this. Even the candidates are not uttering this beats per minute. So even if you are report only the rate, then you have to report it 76 beats per minute. So this is the first mistake, that on the first day it may be you are counting, or in the first instance, not even on the first day, on the first instance it is allowed that you are only counting, but you have to know what other points we have to note. Simultaneously during counting, what can be noted is the rhythm and volume, whether the rhythm is regular or not. So rhythm is either regular or irregular. Now, in case of irregularity also, there is something called regularly irregular and something called irregularly irregular. Like I typically exemplify this: if some student, he or she thinks that I will be absent on all Saturdays, I will be present up to Friday, and then Saturday, Sunday are my off days. Although officially not, as per the institution, Saturday is my off day, so I won't attend on any Saturday, and this is irregularity in terms of discipline or attendance of official attendance from the part of the institution. But this is something regularly irregular. That means there is a regularity in that, pattern in that irregularity. But if some students, if some student that thinks that this week I'll not come on Wednesday and Saturday, that week on Monday, next week on Thursday, like this, there is no pattern in that. This is irregular, of course, no pattern in that irregularity. So similarly, 5 bits are present, 1 absent, again 5 present, 1 absent, or it may be 3 present, 1 absent, 4 present, 2 absent, and it goes on. If you find this type of irregularity, that is regularly irregular pulse. But if there is absolutely no pattern, there is no pattern can be found, it is irregularly irregular pulse. Again, I repeat what I go on repeating in the first year of medical school: probably you will not come across very abnormal findings. In the first year of medical school, students are expected to know the correct procedures, but mostly the findings will be the normal. So in the first year, even in the exam also, most probably your own colleagues will be your subjects. So probably you are not going to find irregular pulses and all. So report it as rate whatever you find regular, and volume mostly will be normal. Now volume normal or high or low, this comes by experience. There is no actual quantitative measurement for it. So what is normal volume? As this pulse wave hits your fingers, I'll just use the word hits your fingers, it is like hitting your fingers. So that is in the first year, in the few months from now, you just try to understand what is normal volume, so that when you find high volume pulse or low volume pulse, you are aware of it, that compared to normal, this should be called high, this should be called low, and this is somewhat a subjective measure. Subjective measurement means, here subjective means this varies from person to person. This is not an objective measurement. Like this wall is a hard structure, I cannot push the wall, nobody can push, so that is objective, it is not subjective. Okay, but whether you can push me out of this room or not depends on your physical ability. So person suffering from malnutrition may not, but many can, many cannot. So those things, this is not a very good example, but still these are examples. Subjective is what varies subject to subject, from person to person, different opinions. Opinions are almost always subjective. I may have a different view on one thing, somebody or other maybe have a different view. So that is the meaning of the term subjective. So volume of the pulse is somewhat subjective, but still you try to understand what is normal volume, and obviously if it is high volume, say reported by 5 medical professionals, it is high volume, obviously the 6th one will not call it low volume. So that much discrepancy does not occur, but still it is somewhat subjective, normovolumic pulse or high volume pulse or low volume pulse. Another thing to note is the condition of the arterial wall. As we keep the fingers, condition of the arterial wall is directly not related to the pulse, this pulse measurement itself, but we measure it along with the pulse, we estimate it along with the pulse, whether the artery is too thick or thin. It is related with cardiovascular diseases, that's why, and it is easy to note it during examination of the pulse itself. The 3 fingers we are using, the middle finger at that moment during measuring the or estimating the condition of the arterial wall, we just, the middle finger, we just press it over that artery, in this case the radial artery, and stop the blood flow through it. So now there is no more, at that point there is no more, sorry, I just correct, we use the proximal most, the index finger, not the middle finger to stop, middle finger is to roll. So proximal most finger, the index finger, to stop the blood flow. And also if there is some backflow, we stop it with the ring finger, these 3 fingers, and the middle finger we roll over the artery. So during estimating the condition of the arterial wall, actually we are not measuring the pulse, neither the rate nor the rhythm nor the volume. We have stopped the seized the blood flow through that artery, and we are just rolling whether it has thickened. Again, this is somewhat subjective, that what is a normal artery, how it feels like, and what a thickened arterial wall feels like with the rolling it with the finger when the pulse has been obliterated, when the blood flow has been obliterated. So that is again a subjective feeling, but thickening of the arteries can be understood by this, the condition of the arterial wall. We note it during measurement of the pulse, but we cannot note it during the first step itself, whether when we are noting rate, rhythm and volume. So for that, blood flow has to be stopped. But we do this if from the examination point of view, at least in the first year, if you are asked to note the pulse for 1 minute, maybe you note for 1 minute, then ask for permission from the examiner that I'll now just note the condition of the arterioles, sir or madam. I'll require a few more, say 30 seconds more, like this. So condition of the arterial wall to noted. And there is something called equality or delay. Equality means whether the rate, rhythm, volume, whatever you are reporting is equal on both sides. So whatever can be done on both sides has to be done, that means bilaterally. So here you measure both the arterial pulses, and you require separately 2 minutes for it. So that is 1 minute for this, 1 minute for that one. So that is noting whether, say if you note that is you have got 75 per minute beats per minute in one hand or one upper limb, but one radial artery, right radial artery. In case of the left radial artery, if you have got it 78, report that rhythm will mostly be, at least now it will be regular, volume okay, normal, condition of the arterial wall, whatever you note, mostly it will be no abnormality, okay, no thickening. Okay, so that is equality. And delay is you have to measure the two sides simultaneously. So whether one is delayed than the other, that is for delay you have to measure simultaneously, even keeping one hand, 3 fingers of one hand on the radial artery and 3 fingers of another hand on the femoral artery. In that case, again you make it convenient. Femoral artery, after you have studied femoral artery, we can do this femoral artery location. So femoral artery, probably will be keeping your dominant hand, right hand on the femoral artery, left hand on the radial artery. So that is if there is any such the delay noted, that is radiofemoral delay, one is coming after the other, not coming simultaneously. In case of the 2 radial arteries simultaneously, it's the radial delay. So this is a bit of a theoretical discussion. And about blood, so these points has to be reported. So till the end of the year, don't go on like this, that I have examined already rate and reported. So that will be completely wrong, not wrong, but I should say very partial reporting, that only rate, and that does not fetch you credit as medical professionals. Rate, rhythm, volume, condition of arterial wall, delay or equality. Now sometimes in the examination, the examiner, if you just utter the word that I have noted the sir pulse, rate, rhythm, volume, I should note the condition of the arterial wall now. Sometimes the examiner now thinks that this person knows, this candidate is well prepared for it, so he or she awards credit for that. That means this is not particular, there is no particular, there is say 20 marks for clinical examination. So the clinician is that is now is aware that this subject, that means this candidate now this knows everything or the important things about this topic, and just then moves on to the next topic. But till the examiner permits, you have to report all these things: rate, rhythm, volume, condition of the arterial wall, delay or equality. Character of the pulse, there is one point if you read in books, but this is clinically not very easy, at least as beginners, to note. So we leave it at this point. At least these 5 points you should note. You will read about the water hammer pulse or not. I think if it has not been discussed till now in the cardiovascular system, this will be discussed in short, and then you will learn again in medicine. In the physiology classes, this will be discussed in very brief if not discussed till now, I don't know. You have the ECG has been discussed, I think, ECG in classes. So those who are not there or those who have joined late, you have to copy it up. Theory classes can't be repeated. So ECG has been discussed, coronary circulation, heart block, myocardial infarction. Very briefly, these are mentioned in your syllabus. At least very briefly, they have been discussed. Cardiac cycle is not yet discussed, I think. Cardiac cycle, no. Cardiac cycle, cardiac output have not been discussed, I think. Cerebral circulation, physiology of shock, these are left. Oh, that is for the theory. These things will be discussed, I think. Sorry. So this is these things you have to note in pulse. About blood pressure, most of you know by now. So tying the cuff and all of you know, at some point of time you have seen someone or your blood pressure has been measured. So again, there are theoretical things to be discussed, but as most of you know or all of you know, or is there anybody who has not attended the class or who don't know still how to measure blood pressure at all? So I think most of you know. We'll just go and do it in the clinical room. There are a few theoretical things to discuss, and I'll again suggest that whenever you read about these topics, now refer at this point, 2 months have elapsed. Now refer to whatever practical textbook you have. If it is already the book by Dr. C.L. Ghai, it's okay. Otherwise, you refer to that book. This is just a suggestion. It will help you in preparing for that topic's theoretical aspects as well. There are many questions and answers given at the end of each topic, in addition to the procedure and all, which is given in every practical textbook. In most of the practical textbooks, questions and answers are given, but that practical textbook by C.L. Ghai is a bit extensive in this regard. So I did not say this before 2 months. Now that all these topics, so many topics had been discussed, only one topic in hematology which you have to perform with your own hands is going on, and clinical will go on. So you try to refer to that book. You can use the PDFs of even earlier editions. You can go to the library and search for the hard copies, but the latest edition. But even if not the latest edition, earlier editions will also suffice for the. This I am telling for your examination purpose, so it will help you. And what we like, I would like to suggest, this is not a compulsion. If you have your stethoscope, if you have your own stethoscope and sphygmomanometer, it will be very good for yourselves. So the department can arrange for a few, or the institution can arrange for a few, but having those as medical professionals, I think this is just my suggestion, that if you have them, carry it during the exam. The cause I have already told you, that simple things like torch, okay, even if not the sphygmomanometer, the stethoscope, if you don't have during the exam, what it does is, sometimes you are asked to do a simple examination, the apparatus right then not available, then the examiner may pass on to some question which the candidate may feel tough to answer. Okay, so it is better to have a torch, measuring tape, a stethoscope by yourself. For the classes also, I would suggest, if you have sphygmomanometers, then it is better. If not, at least a stethoscope. It will help you practice more and more. But clinical examination, only this 1 hour 30-minute session, it will not be sufficient if you don't practice at home also. If you don't have the sphygmomanometer, you do it in the class hours. Whatever you have, and most clinical examinations will not require apparatus. Most will not require apparatus, like general physical examination. In pulse and blood pressure are included in the cardiovascular examination as well as the general physical examination. But there are other things, temperature, maybe a thermometer is required, but pallor, cyanosis, jaundice, clubbing, edema, all this you practice at home. And home means home or hostel, whatever you practice by, I don't know whether you know, by rules, by according to the NMC guidelines, the medical commission guidelines, medical education is strictly residential. Now it's another thing that in private institutions more in private institutions, that hostels, these hostel charges and all, people sometimes, at least some candidates choose to stay out of the residential system, but the medical commission is suggesting that it should be strictly residential, and that is helpful as well. So you should practice clinical examination and all together, making groups. So all these are the purpose, because probably it won't be sufficient, probably not, it won't be sufficient in these, only in these sessions, to acquire these skills very thoroughly. Okay, because there will be descriptions, then there will be classes. We may arrange for a few revision classes, but everything can't be repeated. This today's class is just being done for some people who may have joined late. So we'll just proceed to the lab or the clinical room and do the rest. If there are around 40 people, so you make, say, groups of 8 or 10. Okay, if some of you have the stethoscope, I suggest you carry it. Okay, if some of you have the stethoscope or even the sphygmomanometer, just carry it to the clinical lab, the room. Palpatory and auscultatory methods are not mutually exclusive. That means, in the sense that obviously these are separate things that is to be done separately, not mutually exclusive. Means I cannot go for only palpatory or only auscultatory and report my result. Both are required. In palpatory, only systolic can be measured. So this becomes nonsense, absolutely, that I have done auscultatory but not done palpatory. Palpatory is to be done. The order is also mandatory. That keeping that order: first palpatory followed by auscultatory. So during the exam, if you go straight for this one, auscultatory, then it is wrong, totally wrong. The first thing will be, why you have to do palpatory? Only in the procedure. Why the palpatory is mandatory? Which step in the procedure for? Yes, first you have to know the systolic pressure. Why? Because
it's the any person who is suffering for any type of hypertension, if
yes,
250 or above.
So if you think it like this, that I'll raise up to 160, but actually if the blood pressure is 180 or 190, yes, that is the reason. Okay, that's okay. And always report in, always means not always, but in case of this instrument, in this type of instrument, you have to report it in even figures, because odd markings are not there. Every bit is important. Yes, can blood pressure cannot be 121/75? Obviously it can be. It can even be in decimals if you think in that way. But markings are given at a space of 2, at least 2. Now, if this is the these types of this battery operated, this 122/74 is possible. So you would have done it in the auscultatory method, 122/74. Palpatory, okay, palpatory you have done. So what did you get?
Sir, 92 beats per minute.
No, I am not asking about the pulse rate. By the palpatory method, the blood pressure, what did you get? So if you not done it, that is wrong. Palpatory, you have to measure by the palpatory method followed by the auscultatory method. If you have got it 122, in palpatory you will be getting around something around that. Usually the auscultatory one is greater. Auscultatory reading is greater. So you might have got 110 by the palpatory method. Do you know how to do the palpatory method?
Sir, I think I have to place the stethoscope here and here.
Is it so? Is the stethoscope required during the palpatory method? What is the meaning of auscultation?
Palpatory method is felt.
Palpatory by feeling. So which artery is to be felt? So show it for him. What is the palpatory method? Just make him the subject, make another person who has not been the subject. You be the subject now. Okay, show it. So even if you don't have individually, I'll suggest, if you are roommates or all, try to procure one sphygmomanometer. Otherwise, if you don't practice repeatedly, you will make mistakes. First eye, right? After using once, first deflate properly. Okay. Some candidates have a habit that, sir or madam, this is not working. So then the examiner will himself or herself go for blood pressure measurement and show if he or she can find that the instrument has no error, that is to your discredit, absolute discredit, because you have not deflated properly. Where this should be kept? This also, this you are keeping this. So as beginners, follow everything, whatever is the procedure you follow. Otherwise, you make mistakes. Inflation you have to do. Where will be your own hand? Is it so?
Medial.
So brachial artery. Do you? If you do it with place your hand with the ready brachial artery, I think it will be okay. But as beginners, you don't go outside book teaching. It is the radial artery which is chosen for the palpatory method of blood pressure. You do it on the radial artery. Okay. This feeling of the pulse with your hand, then go 20, 10 or 20 above that, then again you deflate, and when the pulse appears, you note it as the systolic pressure. Usually when the pulse disappears and when the pulse appears, it is the same point. Now you have noted this systolic pressure. Now you go for the auscultatory method. Up to which point you will go? If you had measured at 110, then you may go up to 130 or 40. So you can't go blindly. Now you say, sir, I will go up to 300. If I don't have, even if not done palpatory, if I go up to 300, but think of the convenience of the subject also. It is actually somewhat, if you go up to 300, it will actually hurt him or her. So first palpatory, disappearance of pulse, go 20 above, 30 above. I am not going to the cause right now, it will be discussed, but go 20, this is the procedure, go 20, even a technical person who has learnt once, even who is not a doctor can do this, 20 above, 30 above, deflate, note where the pulse is coming, that means reappearing, that is the systolic pressure. Now after getting it, you can deflate fast, deflation will be slow, you can deflate fast, then after that you do the auscultatory method. Are you roommates? No. So I just told them, if you, even if not individually, you try to have a swing movement. That is my suggestion. 130 by 70. So practice, help your friends. Everybody won't have everything, but help your friends out. Practice at home also, because it won't be sufficient in 1 hour or so. Maximum we can have another class on blood pressure, not more than that. That means this practical part. What are you doing? Class is not for fooling around. If you don't have the sphygmomanometer right, then at least practice the arterial pulse. You can, even with without the sphygmomanometer, that can be done.